Everyone, my name is Gabriel Allaf and I am a psychiatry resident. Thank you for joining me today on my presentation for psychiatric assessment and management and disaster and terrorism casualties. This is going to be another chapter from the Clinical Manual of Psychosomatic Medicine, second edition. While much of the disaster response focuses on physical injuries or toxic exposures, psychiatric symptoms are often more prevalent and longer lasting. From fear driven visits to true psychiatric decompensation, our role is to rapidly assess and manage these presentations within the context of trauma informed care. As an overview, many more individuals seek care for psychological effects rather than actual exposure to trauma or toxins during disasters. Fear often spreads faster than the actual event, which is why psychiatric triage must be integrated very early. Mental health outcomes of disaster events often persist much longer after the physical injuries heal. In general, there are three categories of patients during mass casualty events. First, those who are truly exposed to a toxic or traumatic event, those with underlying psychiatric illness who decompensate, and third, those with no exposure but significant fear. This third category, unexposed but fearful, may constitute the largest group presenting to emergency departments across the country and must be carefully evaluated to prevent overwhelming resources. In terms of symptom overlap and diagnostic challenges, many anxiety-driven symptoms, including tachycardia, dyspnea, and dizziness, can mimic chemical exposure or medical emergencies. These overlaps present diagnostic challenges. For biological agents, fear is a key early warning sign. Providers should be trained to distinguish between toxicological versus psychogenic presentations and always keep autonomic nervous system activation in mind. Trauma care should follow the ATLS structure with a primary and secondary survey. Psychiatric assessment becomes a tertiary survey. Recognizing psychiatric casualties early helps to conserve critical care resources and reduce unnecessary interventions. Standard protocols must be adapted to include medical status evaluations and simple screening questions. A post-disaster psychiatric examination should include a quick history, including prior psychiatric illness, injuries, medications, and suspected exposures. A clinician should look for disorientation, clouded consciousness, and signs of dissociation or panic. These mental status findings can provide rapid clues to differentiate psychiatric versus medical presentations. Delirium often results from hypoxia, infection, medication reactions, or underlying medical issues. It can be confused with panic or disassociation, but usually includes impaired attention and fluctuating consciousness. It is also more common in older adults and requires immediate medical management, not simply antipsychotics or benzos. Depression can often emerge de novo or as a worsening pre-existing condition after trauma. Some depressive presentations mimic prodromal signs of exposure, for example, fatigue and nausea. Timeline, functional changes, and context help differentiate depression from physical illness. SSRIs and therapy like CBT are the mainstays of treatment. Acute stress disorder, or ASD, and PTSD are common post-disaster, especially when physical injury or head trauma is involved. PTSD risk is also higher with prolonged exposure or interpersonal violence. SSRIs, then prazosin for nightmares, and cognitive therapies are proven treatments. It is also important to address comorbid conditions like panic disorder and major depression. Health anxiety also increases during and after disasters, especially when fear and contagion or exposure is amplified by media or public panic. Diagnosis requires persistence of at least 6 months, but acute episodes should be met with reassurance, education, and normalization. Avoid excessive testing once medical causes have been ruled out. Conversion disorder and somatization are commonly triggered by trauma and uncertainty. Patients may present with blindness, mutism, or paralysis without a known medical cause. Psychiatric involvement is essential to redirect diagnostic efforts and provide psychological support without reinforcing maladaptive behaviors. Dissociative symptoms, such as mutism, amnesia, or detachment, are also often overlooked. Gentle questioning, assessing for orientation, and observation of eye contact and affect are useful triage tools. Disassociation may protect patients from psychological overload, but persistent symptoms warrant psychiatric care. Alcohol and substance use tends to rise in both the general population and also amongst responders after disasters. Intoxication, withdrawal, or drug-seeking behavior may mimic medical emergencies or mask underlying psychiatric distress. Always screen for substance use and provide linkage to treatment when safe and feasible. In summary, psychiatric triage must be built into every disaster protocol. Most psychiatric symptoms can be managed with verbal de-escalation, reassurance, and short-term pharmacotherapy. It is important to avoid sedating unnecessarily or mislabeling psychiatric presentations as toxicologic. Ultimately, a collaborative, calm, and structured response ensures the best outcomes for our patients. Thank you for joining me on my presentation today. And here are some references that I have used throughout my presentation and also for you to reference to for your interest. Thank you again, and I hope you have a great rest of your day.